Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
Good morning, everybody. Welcome to Beehive Pediatrics. We're here today in our new conference room. This is a place and a space that we kind of use to meet with our parents and discuss different therapeutic options for their child. We like to do it kind of without the kids present, so parents have a good chance to be able to focus and ask questions and make sure that they really have all the answers that they're looking for. So today we are going to discuss eczema. We briefly touched about it on our last podcast with Dr. Zach Cassuto. We were talking about different types of skin rashes, and one of the most common skin rashes in pediatrics is definitely eczema, and it can present in all different types of ways, and it usually is something that doesn't go away so easily. And so we thought we'd do a deeper dive today into what is eczema, how do we treat it, and various questions regarding the kind of lifestyle surrounding eczema. And so today, back on the show, we have Heather, our medical assistant here, who is always helping us and helping patients out. And so she's prepared a bunch of questions that she often gets from either her friends or different parents in our practice.
Yes. And the first question is, what causes eczema?
It is really important to understand what exactly is the cause of eczema, because that's really going to guide treatment. And it's also really helpful for parents to understand what causes eczema, because it also helps them kind of understand how to best treat their child and how to best support their child through this. So eczema is caused by, we really think, two different types of kind of breakdowns in your skin barrier. The first is that your skin is made up of proteins and lipids, which is just, fats and proteins, basically. And that those fats and proteins start to actually break down, creating cracks and crevices in the skin. Sometimes these cracks and crevices aren't necessarily visible to the naked eye, but we know they exist. And that's kind of part of the dryness. And what you're really missing is something called lipids and flavorin. We think those are the two main proteins and fats involved. And then the second part actually is autoimmune. And so interleukins, which are part of what we call your innate immune system, which is your immune system that kind of just acts on without having to learn. Like when we use vaccines, we're using a different part of your immune system, but the innate immune system is something that just reacts. And so that part, IL-4 and specifically IL-13, and we'll talk about why those are important later, are particularly active in eczema. And what that causes is it leads to a lot of inflammation, and it suppresses your innate immune system, meaning it causes to work less well. And then when your immune system is working less well, we find a lot of these children are colonized with Staph aureus, which is a bacteria that lives on all of our skin. But these children particularly are susceptible to an overgrowth of Staph aureus, and Staph aureus produces a toxin that can be quite painful and cause infections of their eczema. And so it's kind of twofold. And we find in kids who have chronic eczema, like their eczema is around for long periods of time, the inflammation actually plays a bigger role than the breakdown of those lipids and proteins.
Can you prevent eczema?
So that's a really great question, and it's been looked into a lot recently because eczema is kind of in that family of what we call atopy, meaning eczema, food allergies, or food sensitivities, and asthma. And there were some studies, and there have been studies that have shown early introduction of food allergens actually prevents food allergies. So we kind of thought, well, can we also prevent eczema? And there were earlier studies that showed that frequent application of ointment can prevent eczema in up to 50% of patients. But since then, there have actually been two studies, they're both published in Lancet, that kind of refuted that. So the first study looked at they took a group of babies and they applied ointment to them, and they took another group of babies and they did nothing and didn't reduce eczema. And these particular babies were high risk for atopy, meaning they had a family history of either asthma, eczema, or food allergies. And it didn't prevent eczema in those patients. And then they did another study and said, okay, well, what about food allergens? Since they're kind of related, can we introduce food allergens early, and might that prevent, eczema and ointment? So they actually had a group where they did ointment, a group where they did early introduction of food allergens, and a group where they did nothing. And there was no difference in that study either. And then the last thing that they did, which I thought was kind of interesting, there was a study that looked at, well, what about breast milk? Because we know breast milk has lots of great benefits. So could potentially babies who are breastfed have less eczema than babies who are maybe exposed to cow's milk or other forms of formula. And what that study interestingly showed was they do eventually get eczema, but it maybe delays it for a little bit. So maybe during that time of breastfeeding, they're not going to present with eczema, but eventually they will.
Okay. And you said in the studies they applied ointment. What ointment was applied during the studies?
So that's a great question. They applied all different types of ointment, but I think the key here and a lot of the education we talk about with parents is ointments versus creams, right? So the point was that it was ointment, it was not a cream. And what's the difference? Ointments are really more oily and fatty, so you're thinking things like, Vaseline or Aquaphor or ointment-based medications. So sometimes when we prescribe different medications, we have the choice between an ointment and a cream. And creams are more like what you kind of think about when you're putting on normal facial moisturizer, right? Mm-hmm. Something that's kind of like a little bit thinner and less gooey. Mm-hmm. But to go back to the beginning, you asked me what causes eczema. It's really a breakdown of fats and proteins. And so ointment tends to be a better barrier because it is higher in lipids and fats than creams. So if the patient will tolerate it, and most babies will tolerate it, the ointment is better. When you get into those older age patients, sometimes they don't like to feel greasy with ointment and they prefer cream. Mm-hmm. So you really do have to consider the patient and their preference. But if all things being equal, ointment is better.
Dr. Rolnick, is eczema curable?
So far, it is not curable. What we do is we manage eczema. Some children do outgrow eczema, and that's great. But for now, there's no real cure. It's really just treatment and mitigating the symptoms of eczema.
Okay, since there is no cure of treatment, can you give me examples and ways of how to live with eczema long term?
Yeah, so kind of the chronic strategy for eczema, or at least my recommendation is all the time you should be doing basic eczema skincare. And that really means frequent bathing, dry padding, and applying moisturizer 1 to 2 times daily. And then that's different, if there is a flare of eczema. So we can talk about that kind of difference, but basically just really good, keeping your skin nice and clean, right? So you reduce the risk of having some of those bacteria we're talking about, like Staph aureus, and then keeping your skin moisturized to prevent the cracks and breakdowns and inflammation. And then, as you get older, hopefully you grow out of it.
You had mentioned flare-ups. What can cause eczema flare-ups?
Yeah, so that also kind of goes back to what causes eczema, right? So I kind of said in the beginning, there's this breakdown of proteins and fats. And then on top of that, autoinflammation by these interleukins and urinate immune system. And in the chronic patients, the inflammation plays a bigger role. And so we see that the autoinflammation gets kind of revved up and really suppresses the innate immune system, and then you can get, an eczema flare. But you can also get infection on top of the flare. So that's one possibility. One possibility is just more inflammation. One could be more inflammation plus infection. And then there's all sorts of different types of triggers for eczema, right? And that's really patient dependent. Most patients will be triggered by the winter because it's particularly dry, and so they have less moisturizer around. Some patients can be triggered by food sensitivities, and we'll talk about that later, but that's a little more rare. And then some patients really can be triggered by things like stress in their environment. And we don't really understand that role completely, but there are reports of an association between patients reporting stress and their eczema getting worse. And so that kind of begs the question for me, like, what do we do when there's a flare, right? That's usually when these kids are coming into the office and they're like, Heather, please get me to see Dr. Rolnick. My kid's scratching all night, they're not sleeping, they're in pain, and this is just horrible. And so there's different ways we can treat flares. The first if you think about it as a ladder, the first set of treatment is going to be always the bathing and moisturizing. The second thing that you can kind of add on to that are steroids. When you think about topical steroids, because we're thinking topical here, nothing by mouth or systemic, steroids kind of range from low potency to very high potency. And so for eczema, moderate to severe flare, you're really looking for a mid-potency steroid. And the reason for that is it usually works really well. And we don't want to overexpose children to high-potency steroids, not because of the systemic effects, meaning when I say systemic, think when we take steroids by mouth, we worry about kids' growth and their blood sugar levels and all sorts of other side effects. But mid-potency steroids applied to the skin have very low systemic side effects, but they do affect the skin where you place it, and it causes skin thinning. And so we want to use the least potent to do the job. So we usually start with a mid-potency or low to mid-potency and then go from there. If we start with low potency, it's not working, we can increase to a mid-potency. If the mid-potency is not working, then what do we do? Right? So there are other options like topical tacrolimus is an option, and there are some other different therapies you can try out there in an acute time. We can try something called wet wraps, which means you bathe, you pat dry.
Okay.
You put on lotion around the area, and then where the skin is directly having a flare, that's where you put the steroids.
Okay.
And then you put wet dressing. And then sometimes you can put dry dressing on top of that, and then you let it sit for 1 to 3 hours, or if you can leave it on overnight. And that really increases the delivery of the steroids at that local level. And you can use that for a couple days, and that usually also is very helpful.
Dr. Rolnick, we discussed steroid options for eczema. Are there any non-steroid options?
So that is a great question. There are a few non-steroid options, and usually we move to those when the steroids are not working. So the first one and the most common one used is topical tacrolimus, and that's approved for children older than 2. I do like to tell parents, just because I think it's good to be transparent, there is a black box warning on topical tacrolimus that it can potentially be associated with lymphoma and skin malignancies. It's been shown in many, many studies, although to be safe, and I've personally never seen that side effect, but it is there, and so they should be aware of it. The other newer options, there are some topical phosphodiesterases. Those are approved for 2 years and up, and then the very last option would be a subcutaneous biologic, which is an injection that goes under the skin. And we talked earlier about the IL-4, IL-13, which is part of the innate immune system. So this actually targets those 2 interleukins specifically. And this is approved for children 12 years and older. And it actually has been shown to work really well. So patients who use this have a 50 to 75% reduction in symptoms compared to the placebo. So that's a pretty good treatment option, but unfortunately it's really not approved for kids who are until they're a little bit older. And it is an injection under the skin.
And can you put ointment on top of medication?
So again, I think this is a good question, because whenever a patient comes in and they're not responding to steroids, you really want to make sure that they're putting the medicine on correctly. So actually, you would think naturally, I think, that you put the steroid on and then I'm telling you constantly to bathe and put ointment on. So put the ointment on top of the steroid, that should be doubly as great, right? But actually it reduces the potency and absorption of the steroid. So what you can do is alternate them. Still do the ointment. You can do the ointment twice a day, and you can do the steroid at a different time of day. Or what you can do is put the ointment around the skin and then just place the steroid on the part where there's an acute flare. But you don't want to put ointment on top of the steroid. That will actually make it work less well.
Okay, Dr. Rolnick, it's really hard for kids to stop itching themselves. What can we do, or what can you do to stop or help with itching?
That's a great question, because itching is really hard, and it's really hard for little kids to stop it. And it makes the eczema flare much worse, right? Because here you have some skin that's already broken down and sensitive. You potentially have some bacteria living on the skin. And then when you itch it and scratch it, right, that actually breaks down the skin more and causes more inflammation, more damage, and potentially an infection. And we don't have great options out there for itching. Clearly, because it's such a problem. But the 2 things that I do recommend is, one, at nighttime, giving them an antihistamine. It really is the sedation or the sedative effect of the antihistamine that stops itching. It really just helps the child sleep, which is A, very important for their healing, and B, if they're asleep, they can't itch. But we don't have great options for during the day, because most of these medications, the way they work is actually by sedating the child. And so we really just try to mitigate some of that itching at night, and then try to get the skin healed as fast as possible to stop the itching trigger.
Dr. Rolnick, can you use oatmeal baths for eczema?
So I would say you could try it, and if you find it helpful, that's fine. But you should kind of be aware that sometimes oatmeal is a potential trigger for eczema, just like any other the kind of foods. And so if it makes it worse, definitely don't do it. Mostly what helps is honestly just a calming warm bath. that helps calm the child down. It's really nice sleep adjunct, like we talk a lot about anyway. It's a great part of the sleep routine to begin with, and it removes or potentially mitigates some of that cracked and allows you to put the moisturizer on right afterwards. So the bath, actually, glad we kind of talked about it, isn't helpful on its own unless you follow it up kind of with moisturizer. But yeah, so you can try it. It might make it worse. If it doesn't make it worse and helps, great.
Okay. Dr. Rolnick, how frequent should a child be when they have eczema?
So we talked about this a little bit, I think, in the previous podcast, and that's why I wanted to really do a deep dive into this. So that study that I was talking about previously, it really compared soak and moisturize. So soak and then put the moisturizer on twice a week to twice a day. And they found improvement in the twice a day group. I find it might be a little bit hard on a family, depending on how many kids they have and what's going on in their life, to bathe their child twice a day. But if they can, that's great. That's how much I would recommend it. But as frequently as you can do it, no more than twice a day, I don't think. And then just always be, you kind of put them bath, let them soak 10 to 15 minutes or 20 minutes, and then pat them dry. You don't want to rub them dry, and then put the moisturizer on. And ointment is better than a cream.
Dr. Rolnick, you had discussed that antihistamine is a good way to help children sleep with eczema. Is there any other alternatives besides antihistamine?
Yeah, so again, the antihistamine is great for itching in that it sedates children and lets them sleep. But there are lots of studies to show that sleep is a problem for patients with chronic eczema. They're itchy, their skin is uncomfortable. If it's particularly bad, it can affect their social interactions at school, especially school-age kids. There's a lot of unfortunate bullying going on, and that also affects their sleep. So we really want to be mindful to ask our patients with eczema if they're having any difficulty with sleep. And I usually don't recommend melatonin to most of my patients, and we can talk about that separately. But this is one case where there was a study in JAMA Pediatrics that showed 3 milligrams of melatonin administered to patients reduce their sleep latency and help them stay asleep for longer. And so they had decreased eczema severity scores, so it actually helped their eczema, and their sleep latency was reduced by 21 minutes, which is kind of a long time, 21 minutes. And the way the study was designed was the children who took the melatonin then had a period where they didn't take melatonin, and then they studied them for a week after that. That's called a washout and crossover. And the children who didn't take melatonin then had a period without it, and then took it. Mm-hmm. And so we really know that there was something about the melatonin in the study that allowed children to fall asleep faster, but that also helped their eczema. Mm-hmm. And we don't really know why that is yet, but we think that there might be some sort of interplay between melatonin and the innate immune system or the inflammatory cycle of eczema that actually improve their eczema scores. So hopefully, they'll continue to do studies in this area, and we'll find out more about that. But yes, in this particular group, 3 milligrams of melatonin may be helpful.
Can food or stress trigger eczema?
Like I said, there have been associations between stress and eczema flares. We don't really know the exact connection between that, but we can kind of hypothesize that when you're stressed out, it probably does affect your immune system and lead to a flare-up. Mm-hmm. And then food is also a great question. So even though that they're kind of related, in that food allergies, eczema, and asthma all have a role to play with the part of your immune system that is modulated by something called IgE, which is immunoglobulin E. Okay. Food is not often a trigger for eczema, which is really interesting, and I think a common misconception. Mm-hmm. In patients who have very severe eczema, sometimes we will recommend that they eliminate one of the most common food allergen for their age. So the most common food allergen for an infant is going to be cow's milk. Mm-hmm. And the most common food allergy trigger, but not allergen, is going to be egg for eczema patients who are older than 12 months of age. But I really would not recommend eliminating this from your diet unless you're having very, very severe eczema, and then you try it for a week or two. If food is your trigger, you will usually know within a week or two because you will start to immediately get better. And if it's not, I would reintroduce it to your diet. Especially the infants, I don't recommend this because cow's milk is often the formula they're on, cow's milk protein, and it's not often the cause of their trigger. Mm-hmm. And it's often also in maternal diet, and so they're getting exposed to it through the breast milk. Mm-hmm. So because it's not usually the problem and it's a lot to eliminate, I usually don't recommend this unless we're talking about severe eczema. To go back to food kind of allergies, we talked a little bit about how early introduction of food allergies reduces the risk of actually developing food allergies. And so usually a pediatrician will recommend sometime between 4 months to 6 months that you start to introduce these common allergens into your child's diet. After 6 months, it hasn't been shown to be as effective, and so that's why I say 4 to 6 months. But the caveat to that is actually patients with severe eczema should not introduce peanuts on their own. And so the introduction of peanuts in that age group should really be done in conjunction with your pediatrician. Usually we do either as food or we do skin testing or blood testing for peanut allergy in that age group. And then depending on the results of those tests, we will do a food challenge in the office to just safely monitor for any signs of severe food allergies, which would be something like anaphylaxis, where they're vomiting, they can't breathe, they have a big eruption of hives. And so the severe eczema patients and pediatricians should both be aware that those are children who really actually should not have the introduction of peanuts until they've had some testing done. And that's kind of all of our questions I think we have for today. We hope this was helpful to all of our patients with eczema out there. And of course, if you have any questions for Heather or myself, you can leave a comment at the end of the podcast or in the YouTube channel, and we're happy to answer as quickly as we can.
Yes.
Thank you for watching The Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com, and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.